2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults by Orlando Martinez Oliva, Doctor of Medicine. First-degree specialist in internal medicine. Professor of Internal Medicine and Emergency Care. University of Medical Sciences of Havana, Cuba. Welcome. Today we will review the main changes in the new 2025 American Heart Association and American College of Cardiology Guidelines for the Prevention, Detection, and Management of Arterial Hypertension in Adults. First, the universal target remains a blood pressure of less than 130/80 millimeters of mercury for all adults. The novelty is that earlier treatment initiation is now recommended, and in patients with stage 2 hypertension it is suggested to start directly with 2 drugs in combination, preferably in a single pill. Another important change is the introduction of the PREVENT calculator, which replaces the previous pooled cohort equations. This tool integrates cardiovascular, kidney, and metabolic risk and allows for a more precise estimate to decide when to initiate treatment. In special populations, a key update is the reduction of the treatment threshold in pregnancy. Therapy is now recommended starting at 140/90, aiming to reduce maternal and fetal complications. In older adults, individualized targets are maintained, but tighter control is supported when well tolerated. In addition, the guideline recognizes the link between hypertension and cognitive decline, emphasizing that good control may reduce the risk of dementia. The role of the multidisciplinary team and the social determinants of health is also reinforced, as well as the importance of home blood pressure monitoring. Although cuffless wearable devices are not yet reliable for clinical decisions, the use of digital tools is encouraged to improve adherence and follow-up. In summary, the 2025 guidelines invite us to act earlier, to use new risk assessment tools, to better protect vulnerable populations, and to work as a team to achieve more effective hypertension control. These recommendations represent a step forward in preventing cardiovascular complications and improving the overall health of our patients. Asterisk. Introduction to the Hypertension Guideline. Hypertension remains, well into the 21st century, the most prevalent and impactful cardiovascular risk factor worldwide. Nearly half of all adults in the United States, and an increasing proportion in Latin America and the Caribbean, present blood pressure values equal to or greater than 130/80 millimeters of mercury. This translates into millions of individuals at risk for myocardial infarction, stroke, heart failure, chronic kidney disease, and cognitive decline. Against this backdrop, the 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults represents a milestone in updating recommendations for the clinical approach to hypertension. These guidelines are not created in isolation. They are the natural evolution of the 2017 recommendations, which already marked a paradigm shift by lowering the diagnostic threshold to 130/80 millimeters of mercury, a stricter threshold than that used in Europe and other regions. The 2025 version maintains this threshold but introduces significant innovations that reflect advances in clinical research, pharmacology, epidemiology, and behavioral sciences. The central goal is clear: to diagnose earlier, treat more intensively and personally, and effectively reduce the burden of cardiovascular and renal complications associated with hypertension. One of the most relevant contributions of the new guideline is the incorporation of the PREVENT Risk Calculator. Risk Calculator, which replaces the traditional pooled cohort equations. This tool estimates both 10 and 30-year cardiovascular risk, integrating not only classical variables such as age, sex, cholesterol, and smoking, but also renal and metabolic factors. In this way, clinicians have a more precise instrument to decide when to initiate pharmacologic therapy and at what intensity. The guideline emphasizes that therapeutic decisions should not be based solely on blood pressure values, but on the patient's overall risk profile. Regarding pharmacologic treatment, the 2025 guideline reinforces the strategy of initiating therapy with 2 drugs in combination, preferably in a single pill, for patients with stage 2 hypertension, greater than or equal to 140 over 90 millimeters of mercury. This recommendation seeks to improve adherence and achieve faster, more sustained blood pressure control. In addition, new therapeutic options are introduced, such as glucagon-like peptide-1 receptor agonists for patients with obesity and hypertension, and the recommendation to evaluate primary aldosteronism in all cases of resistant hypertension, even in the absence of hypokalemia. Special populations receive particular attention. In pregnancy, the treatment threshold has been lowered to 140 over 90 millimeters of mercury, aiming to reduce maternal and fetal complications based on recent evidence. In older adults, individualized targets are maintained, but tighter control is supported when well tolerated. The guideline also explicitly recognizes the relationship between hypertension and cognitive decline or dementia, emphasizing that good blood pressure control may help preserve brain function over the long term. Another innovative aspect is the consideration of social determinants of health. The guideline acknowledges that socioeconomic status, access to health services, diet, urban environment, and community support decisively influence the prevention and control of hypertension. Therefore, it promotes a team-based care approach, involving not only physicians but also nurses, pharmacists, social workers, and community health workers. Technology also plays a central role. Home blood pressure monitoring is strongly recommended, while cuffless wearable devices are not yet considered reliable for clinical decision-making. However, the use of mobile applications and digital platforms is encouraged to improve adherence, facilitate follow-up, and promote patient education. In summary, the 2025 American Heart Association and American College of Cardiology Hypertension Guideline represents a substantial advance in the fight against one of the leading threats to global health. Its key messages can be synthesized into 5 pillars. 1. Early and accurate diagnosis, supported by ambulatory and home monitoring. 2. More intensive and personalized treatment, with early initiation of combination therapy. 3. Use of new risk assessment tools, such as the Prevent Risk Calculator to guide decisions. 4. Protection of vulnerable populations, including pregnant women, older adults, and patients at risk of cognitive decline. 5. An integrated, multidisciplinary approach, incorporating social determinants, lifestyle interventions, and digital technology. These recommendations not only redefine clinical practice in the United States, but also provide a reference framework for other countries, including those in Latin America, where hypertension remains a growing challenge. Adopting and adapting these guidelines to each local context will be essential to achieving better blood pressure control and, ultimately, a significant reduction in the burden of cardiovascular disease in our populations. Blood pressure targets. Blood pressure targets remain at the very heart of hypertension management. They represent not only numerical thresholds, but also clinical goals that guide therapeutic decisions, influence patient outcomes, and shape public health strategies. The 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults reaffirms and refines the central role of blood pressure targets, building on the landmark 2017 recommendations while incorporating new evidence and perspectives. Universal target, below 130 over 80 millimeters of mercury. The guideline maintains a universal treatment goal of less than 130 over 80 millimeters of mercury for all adults with hypertension. This target reflects the accumulated evidence that tighter control of blood pressure reduces the risk of cardiovascular events, kidney disease progression, and even cognitive decline. The decision to preserve this threshold underscores the consistency of findings across multiple randomized trials and meta-analyses, including SPRINT and subsequent confirmatory studies. Importantly, the guideline emphasizes that this target is not aspirational but achievable. With appropriate lifestyle interventions, early initiation of pharmacologic therapy, and the use of single pill combinations, most patients can reach and sustain blood pressure levels below 130 over 80 millimeters of mercury. Stage 2 hypertension, early combination therapy. For patients with stage 2 hypertension, defined as blood pressure greater than or equal to 140 over 90 millimeters of mercury. The guideline recommends initiating treatment with 2 antihypertensive agents, preferably in a single pill combination. This approach is designed to accelerate blood pressure reduction, improve adherence, and minimize therapeutic inertia. The rationale is clear. Patients with higher baseline pressures are at greater immediate risk, and delaying effective control translates into preventable morbidity and mortality. Risk-based personalization. While the universal target remains below 130 over 80 millimeters of mercury, the guideline introduces a more nuanced framework for personalizing treatment intensity. The adoption of the Prevent Risk Calculator allows clinicians to integrate cardiovascular, renal, and metabolic risk factors into decision-making. For patients with elevated risk, such as those with diabetes, chronic kidney disease, or established cardiovascular disease, achieving and maintaining blood pressure below 130 over 80 millimeters of mercury is considered essential. For lower-risk individuals, the same target applies, but the urgency and intensity of pharmacologic intervention may be modulated. Special populations. The 2025 guideline devotes particular attention to populations in whom blood pressure targets have historically been debated. Older adults. The recommendation is to aim for less than 130 over 80 millimeters of mercury when tolerated, recognizing that frailty, comorbidities, and risk of adverse effects must be considered. The evidence suggests that even in advanced age, tighter control reduces cardiovascular events without significantly increasing harm, provided treatment is individualized. Pregnancy. A major change is the recommendation to initiate treatment at 140 over 90 millimeters of mercury in women with chronic hypertension during pregnancy. The target is to reduce maternal and fetal complications, supported by recent trials demonstrating the safety and benefit of tighter control. Cognitive health. The guideline highlights the association between hypertension and dementia, suggesting that maintaining blood pressure below 130 over 80 millimeters of mercury may contribute to preserving cognitive function. This represents a shift toward recognizing long-term neurological outcomes as part of hypertension management. Lifestyle and non-pharmacologic measures. Blood pressure targets are not achieved by medication alone. The guideline reiterates the importance of non-pharmacologic interventions, including dietary modification, sodium reduction, weight management, physical activity, moderation of alcohol intake, and stress reduction as foundational strategies. These measures are recommended for all patients, regardless of pharmacologic therapy, and are particularly emphasized for those with elevated blood pressure not yet meeting the diagnostic threshold for hypertension. Monitoring and technology. Achieving and sustaining blood pressure targets requires accurate measurement and consistent monitoring. The guideline strongly endorses home blood pressure monitoring, which provides a more reliable assessment of control than office readings alone. Ambulatory monitoring remains the gold standard for diagnosing white coat and masked hypertension. While cuffless wearable devices are not yet validated for clinical use, digital tools and mobile applications are encouraged to support adherence and patient engagement. Social determinants and team-based care. The guideline acknowledges that achieving blood pressure targets is not solely a matter of prescribing the right medication. Social determinants of health, such as access to care, medication affordability, health literacy, and community support, play a decisive role. Therefore, the document promotes team-based care involving physicians, nurses, pharmacists, and community health workers to overcome barriers and ensure equitable achievement of blood pressure goals. Summary and implications. In summary, the 2025 American Heart Association and American College of Cardiology Hypertension Guideline reinforces the central target of less than 130 over 80 millimeters of mercury for all adults, while providing a more sophisticated framework for personalization. It calls for earlier initiation of combination therapy in stage 2 hypertension, risk-based decision-making using the Prevent Calculator, and special attention to vulnerable populations such as pregnant women, older adults, and those at risk of cognitive decline. The message is clear. Blood pressure targets are not abstract numbers, but actionable goals that, when achieved, translate into longer, healthier lives. The challenge for clinicians is to integrate these targets into daily practice, leveraging lifestyle interventions, pharmacologic advances, technology, and team-based strategies to ensure that patients not only reach but sustain optimal blood pressure control. Risk assessment has become a cornerstone of modern hypertension management. The 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults places unprecedented emphasis on evaluating cardiovascular risk as the foundation for clinical decision-making. Rather than focusing exclusively on blood pressure thresholds, the guideline highlights the importance of understanding the global cardiovascular, renal, and metabolic risk profile of each patient. From numbers to risk profiles. Historically, hypertension management was driven primarily by absolute blood pressure values. Patients were classified into stages, and treatment decisions were based on whether their systolic or diastolic pressure exceeded a certain threshold. While this approach simplified clinical practice, it often failed to capture the heterogeneity of risk among individuals with similar blood pressure readings. For example, a 45-year-old non-smoking woman with a blood pressure of 140/90 millimeters of mercury does not carry the same risk as a 65-year-old man with diabetes and chronic kidney disease at the same level. The 2025 guideline explicitly acknowledges this limitation and shifts the paradigm toward risk-based management. Blood pressure remains central, but it is interpreted within the broader context of comorbidities, target organ damage, and long-term cardiovascular risk. The Prevent Risk Calculator. One of the most significant innovations in the 2025 guideline is the introduction of the Prevent Risk Calculator risk calculator, which replaces the pooled cohort equations used since 2013. Prevent integrates measures of cardiovascular, kidney, and metabolic health to provide more precise estimates of both 10-year and 30-year risk of cardiovascular disease. Unlike earlier models, Prevent Risk Calculator accounts for a wider range of variables, including renal function markers and metabolic parameters, thereby offering a more comprehensive picture of patient vulnerability. This allows clinicians to tailor treatment intensity more accurately. For instance, two patients with the same blood pressure may receive different recommendations depending on their calculated long-term risk. Clinical application of risk assessment. The guideline outlines several practical applications of risk assessment in hypertension care. 1. Initiation of pharmacologic therapy. Patients with stage 1 hypertension, systolic 130 to 139 or diastolic 80 to 89 millimeters of mercury, and elevated cardiovascular risk according to Prevent Risk Calculator should be considered for early pharmacologic therapy in addition to lifestyle modification. Conversely, low-risk individuals in this category may initially be managed with lifestyle interventions alone. 2. Treatment intensity. High-risk patients benefit from more aggressive blood pressure lowering, aiming for levels below 130/80 millimeters of mercury. In lower-risk patients, the same target applies, but the urgency and intensity of pharmacologic escalation may be moderated. 3. Choice of therapy. Risk assessment informs not only whether to treat, but also how to treat. For example, patients with diabetes, chronic kidney disease, or established cardiovascular disease may require specific drug classes with proven outcome benefits. 4. Long-term prevention. By incorporating 30-year risk estimates, Prevent Risk Calculator encourages clinicians to think beyond immediate outcomes and consider the lifelong trajectory of cardiovascular health. This is particularly relevant for younger adults, in whom short-term risk may appear low but cumulative exposure to elevated blood pressure poses substantial long-term danger. Special populations and risk considerations. The guideline also addresses how risk assessment should be adapted for specific groups. Older adults. While chronological age is a strong risk factor, the guideline emphasizes individualized assessment, considering frailty, comorbidities, and life expectancy. Pregnant women. Risk assessment includes maternal and fetal outcomes, with treatment recommended at 140/90 millimeters of mercury to reduce complications. Patients with cognitive risk. Hypertension is recognized as a modifiable risk factor for dementia, and risk assessment now incorporates neurological outcomes as part of long-term prevention. Beyond biology, social determinants of risk. A notable advance in the 2025 guideline is the explicit recognition of social determinants of health as integral to risk assessment. Factors such as socioeconomic status, access to healthcare, medication affordability, and community support significantly influence both the development of hypertension and the ability to achieve control. The guideline urges clinicians to consider these determinants when interpreting risk scores and designing treatment plans. Technology and risk monitoring. The guideline encourages the use of digital tools, electronic health records, and mobile applications to integrate risk assessment into routine practice. Home blood pressure monitoring is strongly recommended, not only for diagnosis, but also for ongoing risk stratification. While cuffless wearables are not yet validated, the guideline anticipates their future role in continuous risk monitoring. Implications for practice. The shift toward risk-based management has profound implications. It aligns hypertension care with the broader movement in cardiology toward precision medicine. It ensures that resources are directed toward those most likely to benefit from intervention. It reframes hypertension not as an isolated condition, but as part of a continuum of cardiovascular and metabolic risk. The 2025 American Heart Association and American College of Cardiology Hypertension Guideline elevates risk assessment from a secondary consideration to a central pillar of hypertension management. By adopting the Prevent Risk Calculator, integrating social determinants, and emphasizing long-term outcomes, the guideline provides clinicians with a more sophisticated framework for decision-making. Ultimately, the message is clear: effective hypertension management is not only about lowering numbers, but about reducing overall risk and protecting patients across their lifespan. Pharmacologic therapy remains a central pillar in the management of hypertension. While lifestyle interventions are universally recommended as the foundation of treatment, the majority of patients with sustained elevations in blood pressure ultimately require medication to achieve and maintain target levels. The 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults provides updated, evidence-based recommendations that refine the role of antihypertensive drugs, emphasizing earlier initiation, combination therapy, and individualized treatment strategies. When to initiate pharmacologic therapy. The guideline maintains the diagnostic threshold for hypertension at 130/80 millimeters of mercury. However, pharmacologic therapy is not automatically indicated for all patients at this level. Instead, initiation depends on the stage of hypertension and the patient's overall cardiovascular risk profile. Stage 1 hypertension, 130/139/80 to 89 millimeters of mercury. Pharmacologic therapy is recommended for patients with established cardiovascular disease, diabetes, chronic kidney disease, or a 10-year cardiovascular risk of 7.5% or higher as calculated by the Prevent Risk equations. For lower-risk individuals, lifestyle modification remains the first step with close monitoring. Stage 2 hypertension equals 140/90 millimeters of mercury. All patients should begin pharmacologic therapy, regardless of calculated risk. The guideline strongly recommends starting with 2 agents in combination, ideally in a single pill, to improve adherence and accelerate blood pressure control. Preferred first-line agents. The 2025 guideline continues to endorse 4 major classes of drugs as first-line therapy. 1. Thiazide-type diuretics. 2. Calcium channel blockers. 3. Angiotensin-converting enzyme inhibitors. 4. Angiotensin II receptor blockers. These classes have the strongest evidence for reducing cardiovascular morbidity and mortality. Beta blockers are not considered first-line for uncomplicated hypertension, but remain essential in patients with ischemic heart disease, heart failure with reduced ejection fraction, or certain arrhythmias. Combination therapy and single-pill combinations. A major emphasis of the 2025 guideline is the use of single-pill combinations. Evidence shows that patients started on 2 drugs and 1 pill achieve control more rapidly, with higher adherence and fewer discontinuations. Common combinations include angiotensin-converting enzyme inhibitor or angiotensin II receptor blockers plus thiazide diuretic, angiotensin-converting enzyme inhibitor or angiotensin II receptor blockers plus calcium channel blocker. The guideline discourages the simultaneous use of angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers due to increased risk of adverse effects without added benefit. Resistant hypertension and secondary causes. For patients with resistant hypertension, defined as uncontrolled blood pressure despite 3 agents including a diuretic, the guideline recommends evaluation for secondary causes. Notably, it expands the recommendation to screen for primary aldosteronism in all resistant cases, even in the absence of hypokalemia. Mineralocorticoid receptor antagonists, such as spironolactone or eplerenone, remain the preferred add-on therapy in resistant hypertension. Special populations. Pregnancy. The guideline introduces a lower treatment threshold of 140 over 90 millimeters of mercury for women with chronic hypertension during pregnancy. Preferred agents include labetalol, nifedipine, and methyl-dopa, while angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, and direct renin inhibitors are contraindicated. Older adults. Pharmacologic therapy should be individualized, but the target remains below 130 over 80 millimeters of mercury when tolerated. Careful titration is advised to minimize risks of orthostatic hypotension and falls. Chronic kidney disease. Angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers are preferred, particularly in patients with albuminuria, due to their renal protective effects. Diabetes. All 4 first-line classes are acceptable, but angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers are favored in the presence of albuminuria. Emerging therapies. The 2025 guideline acknowledges the growing role of glucagon-like peptide-1 receptor agonists in patients with obesity and hypertension. While primarily developed for diabetes and weight management, these agents have demonstrated modest blood pressure reductions and cardiovascular benefits, making them a valuable adjunct in selected patients. Other novel therapies, such as renal denervation, are discussed but not yet recommended for routine use pending further evidence. Adherence and access. Recognizing that pharmacologic therapy is only effective if patients take their medications consistently, the guideline emphasizes strategies to improve adherence. Prescribing once-daily regimens whenever possible. Using single pill combinations. Engaging pharmacists and nurses in medication counseling. Addressing cost and access barriers, particularly in underserved populations. Integration with lifestyle and team-based care. Pharmacologic therapy is not viewed in isolation, but as part of a comprehensive management plan. Lifestyle interventions, such as sodium reduction, weight loss, physical activity, and moderation of alcohol intake, remain essential. The guideline also highlights the importance of team-based care, involving physicians, nurses, pharmacists, and community health workers to optimize medication use and ensure equitable access. The 2025 American Heart Association and American College of Cardiology Hypertension Guideline reaffirms the central role of pharmacologic therapy while advancing a more nuanced, patient-centered approach. Key messages include initiating therapy earlier in high-risk patients, starting with 2 drugs in stage 2 hypertension, preferring single pill combinations to improve adherence, expanding screening for secondary causes such as primary aldosteronism, tailoring therapy for special populations, including pregnant women, older adults, and those with chronic kidney disease or diabetes. Considering emerging therapies like glucagon-like peptide-1 receptor agonists in selected patients. Ultimately, pharmacologic therapy is not simply about lowering numbers on a blood pressure chart. It is about reducing cardiovascular risk, preventing complications, and improving quality of life. By combining evidence-based drug therapy with lifestyle interventions, technology, and team-based care, The 2025 guideline provides a roadmap for more effective and equitable hypertension management. Special populations. The management of hypertension cannot be approached with a one-size-fits-all strategy. Certain groups of patients, defined by age, sex, comorbidities, or physiological states, require tailored recommendations to ensure both safety and effectiveness. The 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults devotes significant attention to these special populations, reflecting the growing recognition that individualized care is essential for optimal outcomes. Older adults. Hypertension prevalence increases steadily with age, and older adults represent the largest segment of the hypertensive population. The 2025 guideline reaffirms a treatment target of less than 130/80 millimeters of mercury for older adults, provided therapy is well tolerated. Evidence from trials such as SPRINT demonstrates that intensive blood pressure lowering in older individuals reduces cardiovascular events and mortality. However, the guideline emphasizes individualization. Frailty, comorbidities, polypharmacy, and risk of orthostatic hypotension must be carefully considered. Clinicians are encouraged to assess functional status and life expectancy when setting targets. For robust older adults, intensive control is appropriate, while for those with advanced frailty or limited life expectancy, a more conservative approach may be reasonable. Pregnancy. Pregnancy represents a unique physiological state in which hypertension poses risks to both mother and fetus. The 2025 guideline introduces a major change. Pharmacologic treatment is recommended when blood pressure reaches 140/90 millimeters of mercury or higher in women with chronic hypertension. This adjustment reflects new evidence that tighter control reduces maternal complications such as preeclampsia, angiotensin-converting enzymental abruption, and stroke, as well as adverse fetal outcomes. Preferred agents during pregnancy include labetalol, nifedipine, and methyl-dopa, while angiotensin-converting enzyme inhibitors, ARBs, and direct renin inhibitors remain contraindicated due to teratogenicity. The guideline also stresses the importance of preconception counseling for women with hypertension, as well as close monitoring throughout pregnancy and the postpartum period. Chronic kidney disease. Patients with chronic kidney disease are at particularly high risk of cardiovascular events and progression to end-stage renal disease. The guideline recommends a blood pressure target below 130/80 millimeters of mercury for all adults with chronic kidney disease. Angiotensin-converting enzyme inhibitors, or ARBs, are preferred first-line agents, especially in the presence of albuminuria, due to their proven renal protective effects. The guideline also highlights the importance of screening for primary aldosteronism in resistant hypertension, which is common in chronic kidney disease patients. Additionally, the role of sodium restriction and careful diuretic use is emphasized, given the frequent presence of volume overload in this population. Diabetes mellitus. Hypertension and diabetes frequently coexist, amplifying cardiovascular and renal risk. The 2025 guideline recommends the same target of less than 130/80 millimeters of mercury for patients with diabetes. All four first-line drug classes, thiazide diuretics, calcium channel blockers, angiotensin-converting enzyme inhibitors, and ARBs, are acceptable, but angiotensin-converting enzyme inhibitors, or ARBs, are preferred in the presence of albuminuria. The guideline also acknowledges the emerging role of glucagon-like peptide-1 receptor agonists and sodium glucose cotransporter 2 inhibitors, which, although primarily anti-diabetic agents, confer cardiovascular and renal benefits and modestly lower blood pressure. Their integration into treatment plans for patients with diabetes and hypertension is encouraged when appropriate. Resistant hypertension. Resistant hypertension, defined as uncontrolled blood pressure despite 3 agents including a diuretic, requires special consideration. The guideline expands the recommendation to screen all such patients for primary aldosteronism, even in the absence of hypokalemia. Mineralocorticoid receptor antagonists remain the preferred add-on therapy. Cognitive decline and dementia. The 2025 guideline explicitly recognizes hypertension as a modifiable risk factor for cognitive decline and dementia. Maintaining blood pressure below 130/80 millimeters of mercury is associated with a reduced risk of cognitive impairment. This recommendation reflects the growing emphasis on neurological outcomes as part of long-term hypertension management. Racial and ethnic considerations. The guideline acknowledges disparities in hypertension prevalence, control, and outcomes among racial and ethnic groups. In particular, Black adults in the United States experience higher rates of hypertension and related complications. Thiazide diuretics and calcium channel blockers are often more effective as initial therapy in this population. The guideline also stresses the importance of addressing social determinants of health, including access to care, medication affordability, and community support, as integral components of hypertension management. Summary and implications. The 2025 AHA and ACC hypertension guideline underscores that special populations require special strategies. Key messages include: older adults, aim for less than 130/80 millimeters of mercury when tolerated, but individualized based on frailty and comorbidities. Pregnancy, initiate treatment at 140/90 millimeters of mercury. Use safe agents such as labetalol, nifedipine, or methyldopa. Chronic kidney disease, target less than 130/80 millimeters of mercury. Prioritize angiotensin-converting enzyme inhibitors, or ARBs, especially with albuminuria. Diabetes, same target. Consider angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers and integrate glucagon like peptide 1 or sodium glucose cotransporter 2 agents when appropriate. Resistant hypertension, screen for primary aldosteronism. Use mineralocorticoid receptor antagonists. Cognitive health, recognize hypertension as a modifiable risk factor for dementia. Racial or ethnic groups, address disparities and tailor therapy with attention to social determinants of health. Ultimately, the guideline's approach to special populations reflects a broader shift toward precision medicine in hypertension care. By tailoring recommendations to the unique needs of each group, clinicians can achieve better outcomes, reduce disparities, and improve quality of life for millions of patients worldwide. Lifestyle and social factors. The management of hypertension extends far beyond pharmacologic therapy. While medications are often necessary, the foundation of effective blood pressure control lies in lifestyle modification and in addressing the social determinants of health that shape individual and population outcomes. The 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults underscores that lifestyle and social factors are not optional adjuncts, but essential components of comprehensive care. Lifestyle modification, the first line of defense. The guideline reaffirms that healthy lifestyle behaviors are the cornerstone of both prevention and treatment of hypertension. These interventions are recommended for all adults, regardless of blood pressure stage, and are particularly emphasized for individuals with elevated blood pressure or stage 1 hypertension without additional cardiovascular risk factors. Key lifestyle recommendations include: 1. Dietary approaches. The guideline strongly endorses dietary patterns such as the dietary approaches to stop hypertension diet and the Mediterranean diet, both rich in fruits, vegetables, whole grains, lean proteins, and unsaturated fats. Sodium reduction remains a priority, with a target of less than 1,500 to 2,300 milligrams per day. Lower sodium intake is consistently associated with reduced blood pressure and improved cardiovascular outcomes. Potassium intake should be optimized through diet, particularly from fruits and vegetables, unless contraindicated by kidney disease. 2. Weight management. Achieving and maintaining a healthy body weight is one of the most effective strategies for lowering blood pressure. Even modest weight loss of 5 to 10% of body weight can produce clinically meaningful reductions. The guideline highlights the role of structured weight management programs and, when appropriate, pharmacologic or surgical interventions for obesity. 3. Physical activity. Adults are encouraged to engage in at least 150 minutes per week of moderate-intensity aerobic activity or 75 minutes of vigorous activity, along with muscle-strengthening exercises. Regular physical activity not only lowers blood pressure, but also improves insulin sensitivity, lipid profiles, and overall cardiovascular health. 4. Alcohol and tobacco. Alcohol consumption should be limited to no more than 1 drink per day for women and 2 for men, with lower intake preferred. Complete tobacco cessation is strongly recommended, as smoking amplifies cardiovascular risk in hypertensive patients. 5. Stress management and sleep. The guideline acknowledges the role of psychosocial stress and poor sleep quality in hypertension. Interventions such as mindfulness, cognitive behavioral therapy, and improved sleep hygiene are encouraged as part of holistic care. Social determinants of health beyond the individual. A major advance in the 2025 guideline is the explicit recognition of social determinants of health, SDOH, as critical drivers of hypertension prevalence, treatment, and outcomes. These determinants include socioeconomic status, education, employment, housing, food security, and access to healthcare. Access to care and medications. Patients with limited access to healthcare services or unaffordable medications are less likely to achieve blood pressure control. The guideline calls for system-level interventions to improve affordability and availability of essential drugs. Nutrition and food environment. Living in areas with limited access to fresh produce and healthy foods contributes to poor dietary patterns and higher hypertension rates. Policies that promote healthier food environments are encouraged. Built environment and physical activity. Safe neighborhoods, green spaces, and walkable communities facilitate physical activity, while unsafe or resource-poor environments create barriers. Cultural and community factors. The guideline emphasizes culturally tailored interventions, recognizing that dietary habits, health beliefs, and social support systems vary across populations. Team-based and community-oriented care. The guideline promotes a team-based approach to address lifestyle and social factors. Physicians, nurses, pharmacists, dietitians, social workers, and community health workers all play vital roles. For example, dietitians can provide individualized nutrition counseling. Pharmacists can support medication adherence and education. Community health workers can bridge gaps between healthcare systems and underserved populations. This collaborative model is particularly important in addressing disparities in hypertension control among racial and ethnic minorities, rural populations, and socioeconomically disadvantaged groups. Technology and lifestyle support. Digital health tools are increasingly recognized as valuable adjuncts. Mobile applications, wearable devices, and telehealth platforms can support lifestyle modification by tracking diet, physical activity, and home blood pressure readings. While cuffless devices are not yet validated for clinical decision-making, the guideline encourages their use for patient engagement and self-monitoring, integrating lifestyle and social factors into risk assessment. The guideline integrates lifestyle and social determinants into the broader framework of risk assessment. For example, the PREVENT calculator incorporates metabolic and renal factors, but clinicians are urged to interpret results in light of social context. A patient with limited resources may face greater barriers to achieving lifestyle goals, necessitating more intensive support and follow-up. The 2025 American Heart Association and American College of Cardiology Hypertension Guideline makes it clear that lifestyle and social factors are not peripheral considerations, but central to effective hypertension management. Key messages include lifestyle modification, diet, weight management, physical activity, alcohol moderation, tobacco cessation, stress reduction, and sleep hygiene remains the first line of defense. Social determinants of health profoundly influence the ability to prevent and control hypertension, requiring system-level and community-based interventions. Team-based care and culturally tailored strategies are essential to reduce disparities and improve outcomes. Technology can enhance patient engagement and adherence, though clinical validation remains necessary. Ultimately, the guideline conveys that controlling hypertension is not only about prescribing medications, but also about creating environments and behaviors that support cardiovascular health. By addressing both lifestyle and social factors, clinicians and health systems can move closer to the goal of equitable, sustainable blood pressure control for all populations. Technology and monitoring. The management of hypertension has entered a new era in which technology and monitoring play a central role. Accurate blood pressure measurement, continuous monitoring, and the integration of digital tools are now recognized as essential components of effective care. The 2025 American Heart Association and American College of Cardiology Multi-Society Hypertension Guideline emphasizes that technology is not merely an accessory, but a critical enabler of diagnosis, treatment, and long-term control. Accurate measurement, the foundation of monitoring. The guideline reiterates that accurate blood pressure measurement is the cornerstone of hypertension management. Errors in measurement can lead to misdiagnosis, inappropriate treatment, or therapeutic inertia. To minimize variability, the guideline recommends using validated, automated devices in clinical settings, ensuring proper patient preparation, including rest, correct cuff size, and arm positioning, taking multiple readings and averaging results. The guideline also stresses the importance of distinguishing between office, home, and ambulatory measurements, as each provides unique insights into blood pressure patterns. Home blood pressure monitoring. One of the strongest recommendations in the 2025 guideline is the routine use of home blood pressure monitoring. Home blood pressure monitoring offers several advantages. Provides a more accurate reflection of usual blood pressure than office readings. Helps identify white coat hypertension, elevated in clinic but normal at home, and masked hypertension, normal in clinic but elevated at home. Improves patient engagement and adherence by involving individuals directly in their care. Patients are advised to take 2 readings in the morning and 2 in the evening for at least 3 consecutive days, with results averaged to guide clinical decisions. Ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring remains the gold standard for diagnosing hypertension. Ambulatory blood pressure monitoring records blood pressure over 24 hours, capturing daytime and nighttime values. The guideline highlights its role in confirming the diagnosis of hypertension, detecting nocturnal hypertension and non-dipping patterns, both of which are associated with higher cardiovascular risk, evaluating treatment effectiveness in resistant hypertension. Although ambulatory blood pressure monitoring is not always feasible for routine use, it is strongly recommended in cases of diagnostic uncertainty. Cuffless and wearable devices. The 2025 guideline acknowledges the rapid growth of cuffless and wearable devices, such as smartwatches and fitness trackers that estimate blood pressure. However, it cautions that these devices are not yet validated for clinical decision-making. While they may be useful for patient engagement and self-awareness, treatment adjustments should not be based solely on their readings. The guideline anticipates that future validation studies may expand their role in clinical practice. Digital health and telemonitoring. The integration of digital health platforms is another major theme. Remote monitoring systems that transmit home blood pressure readings to healthcare providers allow for timely adjustments in therapy and reduce the need for frequent office visits. Telemonitoring has been shown to improve blood pressure control, particularly when combined with team-based care and patient education. Mobile applications can support medication adherence, lifestyle modification, and self-tracking of blood pressure. The guideline encourages clinicians to recommend evidence-based apps and to integrate digital tools into routine care when feasible. Data integration and risk assessment. Technology also facilitates the integration of blood pressure data with other health information. Electronic health records can incorporate home and ambulatory readings, risk calculators such as Prevent, and laboratory results to provide a comprehensive view of patient risk. This integration supports personalized treatment decisions and long-term monitoring. Patient engagement and empowerment. The guideline emphasizes that technology should not only serve clinicians, but also empower patients. By giving individuals access to their own data, technology fosters a sense of ownership and responsibility. Patients who monitor their blood pressure at home are more likely to adhere to medications, adopt lifestyle changes, and achieve target levels. Equity and access. While technology offers great promise, the guideline warns of potential disparities. Access to validated devices, internet connectivity, and digital literacy varies widely across populations. To avoid widening health inequities, clinicians and health systems must ensure that technology is accessible, affordable, and culturally appropriate. Community programs and public health initiatives may play a role in distributing validated devices and providing education. Future directions. The guideline anticipates that advances in artificial intelligence, machine learning, and continuous monitoring will further transform hypertension care. Predictive analytics may allow for earlier detection of risk, while integration with wearable devices could provide real-time feedback. However, the guideline stresses that rigorous validation and regulatory oversight are essential before widespread adoption. The 2025 American Heart Association and American College of Cardiology Hypertension Guideline positions technology and monitoring as central pillars of modern hypertension management. Key messages include: accurate measurement is fundamental, with validated devices and proper technique essential. Home and ambulatory monitoring are strongly recommended to improve diagnosis and management. Cuffless and wearable devices hold promise but are not yet ready for clinical use. Digital health platforms and telemonitoring enhance patient engagement and improve outcomes. Equity and access must be prioritized to ensure that technological advances benefit all populations. Ultimately, technology and monitoring are not ends in themselves, but tools to achieve the broader goal of better blood pressure control, reduced cardiovascular risk, and improved quality of life. By integrating validated devices, digital platforms, and patient engagement strategies, clinicians can harness technology to transform hypertension care in the years ahead. Comparison 2017 versus 2025. The American Heart Association and the American College of Cardiology have long provided the most influential guidance on the prevention, detection, evaluation, and management of hypertension. The 2017 guideline was groundbreaking, redefining diagnostic thresholds and reshaping the global conversation on blood pressure control. The 2025 update, developed with multiple partner societies, builds on that foundation while incorporating new evidence, tools, and perspectives. Together, they illustrate the evolution of hypertension management over nearly a decade. Diagnostic thresholds and classification. 2017. The most striking change was lowering the diagnostic threshold for hypertension from 140 over 90 millimeters of mercury to 130 over 80 millimeters of mercury. This reclassified millions of adults as hypertensive and emphasized earlier intervention. Blood pressure categories were defined as normal, elevated, stage 1, and stage 2 hypertension. 2025, the classification system remains unchanged. Hypertension is still defined as greater than or equal to 130 over 80 millimeters of mercury, with the same staging. This continuity reflects the robustness of evidence supporting the 2017 threshold. Risk assessment tools. 2017, cardiovascular risk was assessed using the pooled cohort equations, which estimated 10-year risk of atherosclerotic cardiovascular disease. However, the pooled cohort equations often overestimated risk, particularly in diverse populations. 2025, the Prevent Risk Calculator replaces the pooled cohort equations. Prevent integrates cardiovascular, kidney, and metabolic health indicators, offering both 10-year and 30-year risk estimates. It is derived from contemporary, diverse cohorts and provides more accurate calibration. The threshold for defining high risk is now greater than or equal to 7.5% 10-year risk, compared with the 10% threshold used in 2017. Treatment initiation. 2017. Stage 1 hypertension, 130 to 139 over 80 to 89 millimeters of mercury pharmacologic therapy, recommended only if patients had atherosclerotic cardiovascular disease, diabetes, chronic kidney disease, or a 10-year atherosclerotic cardiovascular disease risk greater than or equal to 10%. Stage 2 hypertension, greater than or equal to 140 over 90 millimeters of mercury pharmacologic therapy, recommended for all. 2025, Stage 1 hypertension. Pharmacologic therapy is now recommended for patients with clinical CVD, diabetes, chronic kidney disease, or a prevent 10-year risk greater than or equal to 7.5%. This lowers the threshold for treatment initiation in high-risk individuals. Stage 2 hypertension. As in 2017, all patients should receive pharmacologic therapy, ideally starting with 2 agents in a single pill combination. Blood pressure targets. 2017. The universal treatment goal was less than 130/80 millimeters of mercury for most adults, based on evidence from SPRINT and other trials. 2025. The same target is reaffirmed, but the guideline emphasizes personalization. For older adults, intensive control is encouraged when tolerated. For pregnant women, treatment is now initiated at 140/90 millimeters of mercury, reflecting new evidence of maternal and fetal benefit. Pharmacologic therapy. 2017. First-line agents included thiazide diuretics, ACE inhibitors, ARBs, and calcium channel blockers. Combination therapy was recommended for stage 2 hypertension. 2025. The same 4 classes remain first-line, but the guideline strongly promotes single pill combinations to improve adherence. Screening for primary aldosteronism is expanded to all resistant hypertension cases, even without hypokalemia. Novel agents such as GLP-1 receptor agonists are acknowledged as adjuncts in patients with obesity and hypertension. Lifestyle and social factors. 2017. Lifestyle modification, diet, sodium reduction, weight loss, exercise, and alcohol moderation was emphasized as the foundation of care. Social determinants were mentioned, but not central. 2025. Lifestyle remains central, but the guideline explicitly integrates social determinants of health. Access to care, food environment, socioeconomic status, and cultural context are recognized as critical to hypertension prevention and control. Team-based and community-oriented care models are strongly encouraged. Technology and monitoring. 2017. Home and ambulatory blood pressure monitoring were recommended, but digital health tools were in early stages. 2025. The guideline elevates the role of home monitoring as standard practice and reaffirms ambulatory monitoring as the gold standard for diagnosis. It also highlights the promise of digital health platforms, telemonitoring, and mobile applications, while cautioning that cuffless wearables are not yet validated for clinical decision-making. Special populations. 2017. Guidance was provided for older adults, Black adults, and patients with comorbidities such as diabetes and chronic kidney disease. Pregnancy recommendations were more conservative, with treatment thresholds at 160/110 millimeters of mercury in many cases. 2025. The scope is broader. Key updates include: pregnancy, initiate treatment at 140/90 millimeters of mercury. Older adults, encourage intensive control when tolerated. Cognitive health, hypertension is recognized as a modifiable risk factor for dementia. Obstructive sleep apnea, screening and treatment are highlighted as part of hypertension management. Summary of key differences. In comparing the 2017 and 2025 American Heart Association and American College of Cardiology hypertension guidelines, both define hypertension at greater than or equal to 130/80 millimeters of mercury, but the tools and thresholds for risk assessment have evolved. The 2017 guideline relied on the pooled cohort equations with a high-risk cutoff of 10% 10-year atherosclerotic cardiovascular disease risk, whereas the 2025 guideline adopts the prevent risk calculator, offering 10 and 30-year estimates and lowering the high-risk threshold to 7.5%. For stage 1 hypertension, therapy in 2017 was reserved for patients with atherosclerotic cardiovascular disease, chronic kidney disease, diabetes, or greater than or equal to 10% risk, while in 2025 treatment is recommended for those with cardiovascular disease, chronic kidney disease, diabetes, or greater than or equal to 7.5% risk. Stage 2 hypertension continues to require pharmacologic therapy for all patients, but the 2025 guideline specifies initiation with 2 drugs in a single pill to improve adherence. In pregnancy, The threshold for treatment has shifted from 160 over 110 millimeters of mercury in 2017 to 140 over 90 millimeters of mercury in 2025. For resistant hypertension, the earlier guideline recommended screening for primary aldosteronism only if hypokalemia was present, while the 2025 version advises screening in all resistant cases. Lifestyle modification was emphasized in 2017, but the 2025 guideline expands this to explicitly include social determinants of health. Finally, in terms of technology, the 2017 guideline recommended home and ambulatory blood pressure monitoring, whereas the 2025 guideline elevates home monitoring to the standard, reaffirms ambulatory monitoring as the gold standard, and integrates digital health tools into routine care. The 2017 guideline revolutionized hypertension care by lowering diagnostic thresholds and emphasizing earlier intervention. The 2025 update consolidates those changes while refining risk assessment, broadening pharmacologic and lifestyle strategies, and integrating social and technological dimensions. Together, they reflect a shift from a purely numerical approach to a holistic, risk-based, and patient-centered model of hypertension management. Conclusions. The 2025 American Heart Association and American College of Cardiology Multi-Society Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults represents a decisive step forward in the global effort to reduce the burden of cardiovascular disease, kidney disease, and cognitive decline. Building on the foundation of the 2017 recommendations, the new document consolidates prior advances while introducing innovations that reflect the latest scientific evidence. The conclusions of this guideline can be summarized in several overarching themes that highlight its clinical, public health, and societal impact. A reaffirmation of diagnostic thresholds and treatment goals. The guideline confirms that the diagnostic threshold for hypertension remains at 130 over 80 millimeters of mercury. This decision reflects the consistency of evidence showing that cardiovascular risk begins to rise significantly above this level. The treatment goal for nearly all adults is to maintain blood pressure below 130 over 80 millimeters of mercury. This universal target underscores the principle that lower blood pressure, when safely achieved, translates into fewer heart attacks, strokes, cases of heart failure, and episodes of kidney failure. Earlier and more personalized intervention. One of the most important conclusions is that treatment should begin earlier in the course of disease, particularly for individuals at increased risk. The use of the new Prevent Risk Calculator allows clinicians to estimate both 10-year and 30-year cardiovascular risk, integrating kidney and metabolic health into the assessment. This tool makes it possible to identify patients who may appear low risk in the short term, but who face substantial long-term danger if blood pressure remains uncontrolled. By lowering the threshold for initiating therapy in high-risk individuals, the guideline promotes a more preventive and proactive approach. Combination therapy as the standard for stage 2 hypertension. The guideline concludes that patients with stage 2 hypertension, defined as blood pressure greater than or equal to 140 over 90 millimeters of mercury, should begin treatment with 2 medications, preferably in a single pill. This recommendation is based on strong evidence that combination therapy improves adherence, accelerates blood pressure control, and reduces therapeutic inertia. The emphasis on single-pill combinations reflects a patient-centered approach that seeks to simplify regimens and improve long-term outcomes. Integration of new pharmacologic options. The guideline acknowledges the role of emerging therapies, including glucagon-like peptide-1 receptor agonists in patients with obesity and hypertension. These agents, originally developed for diabetes and weight management, have demonstrated cardiovascular benefits and modest blood pressure reductions. Their inclusion reflects the growing convergence of metabolic and cardiovascular medicine. The guideline also expands recommendations for screening and treating primary aldosteronism, recognizing its prevalence in resistant hypertension. Special attention to vulnerable populations. The conclusions highlight the importance of tailoring therapy to special populations. In pregnancy, treatment is now recommended beginning at 140 over 90 millimeters of mercury, a significant change from prior practice. In older adults, intensive control is encouraged when tolerated, with careful attention to frailty and comorbidities. The guideline also recognizes hypertension as a modifiable risk factor for dementia, underscoring the importance of blood pressure control for preserving cognitive health. Lifestyle and social determinants as essential components. The guideline concludes that lifestyle modification remains the foundation of hypertension prevention and treatment. Dietary patterns such as the dietary approaches to stop hypertension diet, sodium reduction to less than 1,500 to 2,300 milligrams per day, weight management, physical activity, moderation of alcohol intake, and tobacco cessation are universally recommended. Beyond individual behaviors, the guideline explicitly incorporates social determinants of health, acknowledging that socioeconomic status, access to care, food environment, and cultural context profoundly influence outcomes. This represents a shift toward a more holistic and equitable model of care. Technology and monitoring as standard practice. The conclusions emphasize that accurate measurement and ongoing monitoring are indispensable. Home blood pressure monitoring is now considered standard practice, while ambulatory monitoring remains the gold standard for diagnosis. Digital health platforms and telemonitoring are encouraged to improve adherence and facilitate team-based care. Although cuffless wearable devices are not yet validated for clinical decision-making, their potential role in patient engagement is recognized. Team-based and community-oriented care. The guideline concludes that hypertension management is most effective when delivered through a team-based model. Physicians, nurses, pharmacists, dietitians, and community health workers all have essential roles. This collaborative approach is particularly important for addressing disparities in hypertension control among racial and ethnic minorities, rural populations, and socioeconomically disadvantaged groups. A vision for the future. The overarching conclusion of the 2025 guideline is that hypertension management must be comprehensive, preventive, and patient-centered. It is not enough to lower numbers on a chart. The true goal is to reduce overall cardiovascular risk, prevent complications, and improve quality of life. By integrating earlier intervention, combination therapy, new pharmacologic options, lifestyle modification, social determinants, technology, and team-based care, the guideline provides a roadmap for more effective and equitable hypertension control. Final reflection. The 2025 American Heart Association and American College of Cardiology Multi-Society Hypertension Guideline affirms that hypertension is both the most common and the most controllable risk factor for cardiovascular disease. Its conclusions call for a shift from reactive treatment to proactive prevention, from isolated clinical encounters to integrated care, and from a narrow focus on blood pressure numbers to a broader vision of lifelong cardiovascular health. If implemented widely, these recommendations have the potential to transform outcomes for millions of people worldwide. References. Farewell video script. Dear colleagues, students, collaborators, and friends, today we reach the end of a journey we have shared together. A journey filled with learning, challenges, and, above all, growth, both human and professional. A farewell is never a final point. It is a pause that invites us to look back with gratitude and to look forward with hope. Throughout this time, we have worked together toward a common goal: to better understand high blood pressure, its risks, its implications, and the new recommendations that science offers us to confront it. We have reviewed the evolution of international guidelines, from those published in 2017 to the most recent in 2025, and we have reflected on how to translate that knowledge into concrete actions that benefit our patients and our communities. But beyond the numbers, the diagnostic thresholds, and the therapeutic strategies, what truly unites us is the conviction that medicine is an act of service. Every lecture, every discussion, every reading has had, in the background, the lives of the people who trust us. And it is that trust that obliges us to remain updated, to be rigorous, and at the same time, profoundly human. I want to thank each of you for your commitment. To those who participated actively with questions and comments, thank you for enriching the dialogue. To those who listened attentively, thank you for your openness and willingness to learn. And to those who shared this knowledge with others, Thank you for multiplying the impact of our collective effort. A farewell is also a moment to recognize that the path of medicine is never walked alone. We are part of a network of colleagues, institutions, and communities that sustain and inspire us. Science advances because of collective work, and medical education is strengthened when we share experiences and knowledge. Today we close this chapter, but we do so with the certainty that what we have learned will remain alive in every consultation, in every class, in every clinical decision. High blood pressure will continue to be a global challenge, but also an opportunity to demonstrate that prevention, comprehensive care, and empathy can transform lives. I invite you not to see this farewell as a goodbye, but as a see you soon. May each of you carry with you not only concepts and figures, but also the motivation to continue researching, teaching, and caring. Let us always remember that behind every blood pressure reading, behind every prescribed treatment, there is a story, a face, a family. I conclude with a sincere wish that the knowledge acquired here becomes action, that action translates into health, and that health becomes the foundation of a full life for those who trust us. Thank you for your time, for your dedication, and for your vocation. Let us continue forward with the certainty that medicine is and will always be a bridge between science and humanity. Thank you very much.